We have a 58-year-old patient with obesity, dyslipidemia, and fatty liver disease. This is the patient that we're going to have to deal with now. There is no conflict of interest for this presentation, and we have this 58-year-old male with BMI, body mass index of 36 kilograms per square meter, dyslipidemia, and elevated aminotransferases. His total cholesterol is at the level of 245 milligrams per dl, with an HDL at 35 milligrams per dl, an LDL of 170 milligrams per dl, 200 milligrams per dl triglycerides, an AST of 55 and ALT of 86, and gamma GT of 90 units per liter, and a glucose of 155 milligrams per dl, and with normal kidney function. He smokes 30 cigarettes per day for 35 years, and he's an infrequent alcohol user. So we have these obese patients with lipidemia, elevated aminotransferases, which guides us, let's say, to a fatty liver disease diagnosis, but not yet a typical diabetic patient. That's very important, which we'll have to deal with that later on. So the laboratory test for hepatitis and other causes of elevated hepatic enzymes were negative. The ultrasound showed us that really the patient really suffers from fatty liver disease. So the ultrasound confirmed diagnosis of fatty liver disease. And then we had to do a FIB4 test, which was the level of 2.15. So we had an indeterminate level of fibrosis. So we had then to refer the patient for fibroscan, which revealed a medium level of fibrosis. So now what do we have to do with this patient? Let's see what happens with this syndrome now, which we have to say that its name was changed recently for non-alcoholic fatty liver disease to metabolic-associated dysfunction fatty liver disease and metabolic-associated dysfunction steatohepatitis. So it is a syndrome with clinical and laboratory parameters. Its main feature is a broad-spectrum lipid infiltration of the liver, over 5%, excluding, and this is very important, the use of alcohol. And what do we mean by that? 2 alcoholic beverages or less per day, and of course, other causes of steatosis, as we've already said, which cause of chronic hepatitis. And probably many of you would think that it will be, let's say, a problem of Western Europe countries and North America countries. But no, this is not the case. If we do this projection, as you see, from 2000 to 2030, of course, we see that there's going to be an increase in the incidence of the disease of a level of 32% in Europe or 72% of North America. But you see that these extreme numbers, 104% in China, an increase of 104% in China, of 150% in other Asian countries, of 162% in Sub-Saharan Africa, or 148% in Central and South America. So you see, this is not a problem only of, let's say, the people who live well in Western Europe and Northern America. It's a whole world problem. It's a global problem, a global disease, a global epidemic. So what exactly is this? It's a disease that affects up to 35% of adults and nearly 5% of children. And how this disease is created, how it proceeds. We see here that the fat accumulates in the liver, then it progresses to fibrosis. That means a fat plus inflammation and scarring. And the fibrosis goes on to become cirrhosis. That is, what does that mean? Of course, that scar tissue replaces the liver cells. And that also, what does it mean? Finally, that we have liver failure and also an increased risk of hepatocellular carcinoma. The MASH, also the steatohepatitis, accounts to 5 to 7% of adult Americans and up to 20% of obese patients. And the problem is, the real danger is that the majority of these individuals have no symptoms at all, and in many cases, they have a normal examination. But you see here that in the liver, a lot of changes happen. The accumulating fat causes the ballooning of the liver cells, which progresses to the fibrosis, the scarring, and the cirrhosis. it's very important now to see that it's not only a metabolic disease. Actually, there are two elements to it. There is a metabolic element and, in many cases, a genetic element. And these two elements tend to overlap with each other. There is, of course, the metabolic element, as we have already seen, with diabetes, the cholesterol, the obesity, overall and central obesity, but also the genetic element. That is, that some people tend, from their nature, tend to present with the non-alcoholic, with metabolic associated dysfunctional liver disease. And often this fatty liver disease drives them to develop metabolic syndrome and diabetes. That explains why in many cases lean people, lean patients present with fatty liver disease, even if they don't typically acquire, let's say, they don't typically present with the elements of metabolic syndrome and metabolic liver disease. So there is this overlapping of metabolic factors and genetic factors. And of course, there is this, let's say, whole pathogenesis of the disease. I'm going to explain a couple of things. I'll try to do it in a very simple manner. So the problem here is the accumulation of the fat and the free fatty acids and the chylomicrons that are, let's say, accumulate in the liver are the big problem of that, are the real problem of that, because what do they do? They kind of result in insulin resistance. They cause defective insulin signaling. The free fatty acids cause defective insulin signaling, and this causes insulin resistance. And also mitochondrial dysfunction, and the effect of mitochondrial dysfunction is the inflammation, the fibrosis, the apoptosis, the endothelium reticulum stress, and adipose tissue dysfunction, which has everything to do with interleukin 6 and TNF-A factor, a dysbiosis, an inflammatory state, which causes the whole inflammation of the liver and the final destruction, which cannot be averted. The thing that, as you see, the progression is 25 to 35% of these, let's say, non-alcoholic fatty liver disease patients are going to end to NASH, to steatosis, and 9 to 20% of these are going to develop cirrhosis, and the 40 to 60% of these patients are going to have to end in liver failure or hepatocellular carcinoma, and they have to undergo a liver transplantation. And now, how does this, let's say, non-alcoholic fatty liver disease progress? A study using paired biopsies estimated that there's an increase in one fibrosis stage every 7 years. And the disease was estimated to increase by one fibrosis stage every 14 years. So now, how do we set the diagnosis these kinds of patients? Of course, as we already have said, we have to exclude other causes of steatosis, like alcohol or viral causes, etc. We have, of course, the laboratory tests, which are not always abnormal, but in many cases, the transaminases and the ferritin as an inflammation factor are elevated. And of course, the most important are the liver imaging tests, like the UVR ultrasound, the liver fibroscan, the liver CT and MRI. But the thing is that, the gold standard is the liver biopsy. Of course, it's a very difficult procedure, and we really have to select the patients that they have to undergo biopsy. But the thing is that now we have these scores, this scores that they let us establish the diagnosis without this intervention, without having to, have the patient undergo a liver biopsy, like the NAS score and the FIB4 score, which sets the diagnosis with a score over 1.30. So we have all these now clinical predictors of fibrosis that really help us to evaluate a patient without, let's say, proceeding directly to the biopsy. And now the thing is that some people think that, okay, so what about that? Is that only probably, let's say, it's not that big a number of patients that are going, let's say, to proceed to liver failure and hepatocellular carcinoma. But it's not only that. The thing is actually the metabolic associated fatty liver disease, the metabolic associated liver disease, it is a condition that affects many other organs in the human body. As we see here, it is directly associated with a chronic kidney failure, with chronic kidney disease. Also, it can also be associated with atherosclerotic, atherogenic dyslipidemia, inflammation, oxidative stress, hypertension, and it can result in chronic heart disease and also in heart failure. And what does all the statistics tell us? That there is an increase in the readmissions of elderly patients who are admitted of acute heart failure, which it's exactly they're exactly associated with people who have non-alcoholic fatty liver disease. And we see that when people have also, apart from acute heart failure, a chronic MAFLD, then the possibility of them to be readmitted to the hospital increases dramatically. So what can we do about all these people? Of course, there is the weight loss and the exercise, which have shown us that, okay, they can help people, they can help, let's say, they can cure the fatty liver disease. But also there are many of, let's say, drugs, well-known, not so well-known, have been put to the test for the treatment of these people. Metformin, the well-known and well-beloved metformin, in one of those medications. But the thing is that the results have been quite conflicting. Of course, it shows that it can, let's say, ameliorate the liver indices, the biochemical indices. It can help, let's say, with the fatty liver disease, but it did not help with the fibrosis. It did not improve the fibrosis, and there were really conflicting disease about how it can help these patients. The pioglitazone the thing's a little bit better because the histological findings showed an improvement. So we had also a glycemic and lipid profile improvement, but also a reversal of inflammation with pioglitazone, as it was shown in many patients that undergo biopsy. And we see that here that probably we can tailor therapy to those most likely to respond. But also other, let's say, medications that are used to prevent metabolic disorders and to, let's say, to treat diabetes have shown promise in the treatment of metabolic non-alcoholic fatty liver disease. So the efficacy of alogliptin in these patients was shown, and also other peptidase 4 inhibitors. It shows that also there was an improvement in liver indices, but also an improvement in the steatosis of the liver. But also the GLP-1 agonists, liraglutide, there was this great, let's say, this very interesting study with liraglutide, which showed the safety and efficacy in patients with non-alcoholic steatohepatitis, which was a multicenter, the LEAN study, a multicenter double-blind randomized placebo-controlled phase 2 study, which showed that there was also an improvement in liver indices, but also an improvement in glucose, and also an improvement in fatty liver disease. In semaglutide, the results here are even more interesting. That, okay, of course, we know that since semaglutide can be used, let's say, is used to treat diabetes and also has a very significant effect on body weight. So actually, we could expect probably that there would be a very interesting result in the metabolic induced fatty liver disease. But the results are really, really very impressive, with very interesting results concerning the biochemical indices, the aminotransferases. And you see here that when one increase the dose of semaglutide from 1.1 to 0.1 to 0.2 milligrams, and then to 0.4 milligrams, the results are even better, are even more impressive. And also, apart from this, we also have a resolution of the steatohepatitis, not only the results of the biochemical indices, not only, let's say, the results of the liver disease, but also we have a resolution of the steatohepatitis with the use of semaglutide, as shown in these biopsies. So, and this, of course, is very important because as you see here, with different, let's say, doses of semaglutide, we have an even more impressive change in the fibrosis stage. And when we proceed to the even newer drugs, and the tirzepatide, who is a combination of GLP-1 and GIP-1 medications factors, we see that the tirzepatide with this double combination, 50 milligram tirzepatide when compared to 1 milligram of semaglutide, it's an even greater effect on the liver and on the liver disease and the liver fibrosis and the steatosis, that the effect was even more impressive. But also another medication of another category of medications that we have used in diabetes and heart failure, the sodium glucose transferase 2 inhibitors have shown also very much promise in the treatment of fatty liver disease. And there is this very interesting study that showed that empagliflozin combined with linagliptin, a DPP-4 inhibitor, prevented steatohepatitis in this study. Now, but also there is also, let's say, this great point of research where we have new medications, new drugs. So there is this study that, let's say that it was in a New England Journal of Medicine that was published this year, used this new drug. Sorry, let's see. It's the Maestro study. An ongoing phase 3 multinational double-blind randomized placebo-controlled trial which assessed the efficacy and safety of resmetirom, this new medication, this new category of medications in adults with biopsy-confirmed non-alcoholic steatohepatitis and liver fibrosis. And this a new kind of medication showed us very much promise because, as you see this, because this THR beta agonist acts on multiple hepatic pathways to maintain liver health by controlling de novo lipogenesis, fatty acid oxidation, the mitochondrial biogenesis, cholesterol metabolism, and also it has a direct anti-inflammatory effect. And what this study showed us, the Maestro NASH outcomes trial showed us that the medication was very well tolerated, but also reduced liver chemistry tests and also the results of the FibroScan. Now I'm going to take you a little bit back because, okay, we have shown that all these new medications have, let's say, have shown many promising results in the treatment of non-alcoholic fatty liver disease. But what about our patients? Because our patient is not diabetic. So officially, we cannot, let's say, use these medications on him. But now let's take some steps back and go back to another very well-known category of medications that we have used for many years. And we'll take you to, let's say, this Greek study at the Lancet, which showed the efficacy and the safety and efficacy of long-term statin treatment for cardiovascular events in patients with coronary heart disease and abnormal liver tests in the Greek atorvastatin and coronary heart disease evaluation, the Greek study. So this study showed that not only the patient that received atorvastatin, let's say, had, let's say, a reduction in the cardiovascular events, but also had, let's say, an improvement in the liver function tests. And there was a positive analogy between these two. So there was the ATTEMPT study, which assessed the treatment effect in metabolic syndrome without perceptible diabetes in middle-aged men and women, and showed that the effect of atorvastatin treatment on liver function tests in patients with metabolic syndrome and fatty liver disease was really impressive. There was a great improvement in these indices. And also the IDEAL study, which compared atorvastatin 80 milligrams per day to simvastatin 20 milligrams per day, showed an analogous effect. So the effect of intensive lipid lowering with atorvastatin on cardiovascular outcomes in coronary heart disease patients with mild to moderate baseline elevations in aminotransferase levels showed that there was, let's say, at the same time, a decrease in cardiovascular events, but also an improvement in the liver and non-alcoholic fatty liver disease at the same time. And another study that happened also that also was happened in Greece showed the resolution of non-alcoholic steatohepatitis by rosuvastatin monotherapy in patients with metabolic syndrome. And the use of rosuvastatin in these patients showed very promising results, but not only the resolution of fatty liver disease, but also the resolution in the progression, a halting the progression of the fibrosis. And as we see here, not only the total cholesterol and high residual CRP, okay, were all, let's say, the inflammation, the metabolic and inflammation indices were improved, but also there was a resolution in the liver, and the liver enzyme changes also, let's say, went hand to hand with a resolution in the fibrosis. The statins also, when many studies showed that which was biopsy showed an improvement with the statins in metabolic associated dysfunction, fatty liver disease, and steatohepatitis, and also our study where we used 3 statins, rosuvastatin, atorvastatin, and pitavastatin in army personnel, showed not only, let's say, an improvement in their lipidemic profile and the liver biochemistry. The 3 statins showed, all the 3 statins showed this improvement, but also an improvement in the NAS and FIB-4 score, which meant that also the fatty liver disease improved and was treated very effectively. Now, of course, there are many medications that now, let's say, in the progress of different studies, different phase studies. And let's not forget about the bariatric surgery, which is an option in patients unresponsive to lifestyle changes and pharmacotherapy, reduces weight and metabolic complications, and has stable results in the long term. So actually, the fatty liver disease associated cirrhosis is one of the top 3 indications for bariatric surgery. Now, what do we do with these patients? Our first thing to do now is we have to evaluate the cardiovascular risk, the 10-year cardiovascular risk for these patients, the Hellenic score 2. And using this score, we see that we have a patient who is of a very high risk. And what we do with this patient, we now have to target, of course, his LDL cholesterol so as to deal with cardiovascular disease prevention first. So now, according to the guidelines for these very high-risk patients, we have to achieve, using a statin, at least a 50% LDL reduction from the baseline, and also an LDL goal of less than 55 milligrams per DL. So what did we do with this patient? We had him in, a schedule for weight loss. We subscribed 20 milligrams of rosuvastatin with escalation to 40 milligrams and ezetimibe 10 milligrams per day to achieve this goal of less than 55 milligrams per DL of our goal of LDL of less than 55 milligrams per DL. And also, since he is not an officially diabetic patient, the only medication that we could use according to the guidelines was pioglitazone 15 milligrams per day. And then we achieved a cholesterol of 120 milligrams per DL, an HDL of 38 milligrams per DL, an LDL of 54 milligrams per DL. We had an improvement in ALT and AST with a normal liver function. And the ultrasound and histologic findings also showed improvement in our patients. And now just one last look at the guidelines. Let's say we have to really think about these patients. We have, let's say, to research them, to evaluate with non-invasive testing the fibrosis, like the FIB-4, the score. We have to, let's say, to determine the risk for fibrosis and for cirrhosis, and then we have to take further steps in order to treat them and prevent them, the progression to fibrosis, to cirrhosis, and possibly liver carcinoma. Thank you very much for your attention.